to show that we've made a diagnosis of what's causing us to not achieve these targets, and then what are we planning to do in the future instead of us coming just to drop them.
I'm not averse to that, honorable member, but it will be a book about this big. I'm not averse to it, but what I would suggest to you is that perhaps, and as I still have a few questions myself, just ponder over your report that's before you. Maybe let's do this. Let's choose a few, rather than say bring a full comprehensive report and then they know why they are not achieving it. If you ask about anything, they will give you a reason why they are not achieving it. Some of which we are going to ask now. But I think asking the department for an entire report on all of them, because if you look at what was presented now, how many green did you see? If you saw maybe 2 or 3 or 5, the rest were not. And its targets, they set by their own admission. So, perhaps redirect your question. I would say that the acting HOD or whoever she tasked to respond to it would rather tell us in general terms for now, to say that, look, we've not achieved X, Y, and Z for whatever reason. Would you be amenable to that?
I think Chair will just give them the list of the one specific, but I was more specific to the one set by national, because that should cover the national standard. Okay. So those ones should not be a big list.
That's fair. So I think that's actually a reasonable request from the honourable member. Ms. Nchele, if we'll note that they will provide a report for us on the national targets and reasons why they could not achieve them. But HOD, if you still care to respond, other than to send it to us in writing, if you just want to briefly comment on the honourable member's request.
Thanks, Honourable Chair. Honourable members, I think in the next report that we are going to present on the quota performance, there are reasons for underachievement and why we've achieved. This one is still a plan and doesn't have reason for non-performance, but in the one that we are going to table next, which is the performance, there are reasons for underperformance. Thanks.
Honourable members, you'll remember the acting HOD's opening remarks as well, that a final draft will come around March, end of March. We will have to adopt these, but as we did with the previous ones, when we move towards the budgets where we have to adopt these things, we must make inputs now. Otherwise, we stand up in the House and say, oh, you didn't do this and you didn't do that, and then you didn't make the inputs here today and now. Then we blame the department and we say, oh, the MEC this and the MEC that. So if you want to make those contributions, and even if you want to send it after this meeting, it's fine. If I receive any correspondence from yourselves, I'll compile that correspondence and send it off to the department to include in their submissions. So in as much as we're here to talk about it, it's not the end of the process. You also have the opportunity, and may I remind honourable members, to submit parliamentary questions. It guides the process because it is eventually signed off, those questions, by the MEC and the HOD, acting HOD. And so they consider that in the submissions. Nothing also stops you from writing to the MEC. So use the mechanisms that are available, but you can certainly send it here because we're dealing with this here and we'll appropriately raise it for you. On that, yes.
Thank you very much, Honourable Chairperson, and good morning once again to your good self. I just wish to take this opportunity, Chair, on what your remarks have been on. I know that I'm just a replacement, but I'm happy, Chairperson, that you are raising such a matter that honourable members must look at the APP and make contributions now. And I just want to take this opportunity as the chairperson on the Quality of Life chairperson and say that most of the time we talk about when we do assessments of APPs and we wish to look at them in a gender responsive manner, we always echo the concern that we fail to apply a gender lens to our APPs at a planning stage. So I think, Chairperson, it's important that when we deal with APPs, we seize this opportunity as honorable members to look into the APPs in a gender responsive way, whether we do apply the principle of the gender responsive planning, budgeting, evaluation and monitoring. So I just wish to reiterate what you've spoken on, but add the element, Chairperson, that it's important for us to also look into it with the gender lens. Thank you very much.
Thank you, Honorable Member and Chair of the Quality of Life Portfolio Committee, for bringing her committee matters to us. I think the Department of Health looks at different lenses. I'm not going to answer for the acting HOD, but if we look at underage pregnancies, there is an indicator there. If we look at disability, there is an indicator there. If we look at, there is nothing particular to geriatrics that I have seen that is senior citizens. However, the department is responsible for that area of medicine. So I think I'm not downplaying your comment, but I'm trying to say that the department deals with the consequences. But I think it works both ways. I think the department deals with what walks through their doors. So, for example, we have underage pregnancies, and there is a figure that is reported in these reports, quite a large number of underage pregnancies, there's up to 14 years old. So there are a number of them. The department's job is to deal with the pregnancy that walks through the door, record it, and as the Honorable De Boer has previously raised from many platforms to say that they should be responsible for also reporting this to SAPS, for example. However, even though we may look at it through that lens, it falls elsewhere. For example, the programs, preventions, advocacy. So I think there's a dual role. I think the department should probably get involved in the area, because the time for departments to work in silos should end. I think all of these societal issues that the Department of Health deals with and reports on should be dealt with a whole of government approach. Because for as long as we don't look at the cases of GBV that need stitches and that have a broken arm, or beaten up and end up in our ICUs, or our children that are raped, and even our other even those that are not children who are raped, that walk through our doors. So it mustn't just be one department, social development, or it should be. And on that note, Chairperson of Quality of Life, I think your committee is uniquely placed to actually bring all of them together. So I would be happy, because I serve on your committee, that one day you bring the HOD of health and one day and social development and community safety all in one room, and we work on a program. So thank you for your contribution. I think it's very important, and I think it emerges therefrom that this approach needs to be taken. So I think it's advice to the department from the side of the honorable member and the contributions and remarks that we've made. And you'll hear it from the honorable members in the House, when they stand up and talk from the podium. This is exactly what they are saying. So we're not saying that you don't. It is just to take on board from the honorable members. So I hope you take that on board. Thank you. Have I encompassed that, Honorable Masiko, Chair? Okay, is there any follow-up or other response that you wish to the department to give you? Covered, thank you very much. Any other honorable member? No. In the opening remarks of Mr. Governor, he made a remark that should shake us. He said it's very much the same. It can't be very much the same. It must move, the needle must move. So when we get an APP after APP after APP and we get somebody telling us it's very much the same, that should be the most concerning thing to us, because it shouldn't be. So that's the first thing. Again, honorable members, when we look at the department's presentations, they start off in all of their presentations with a mission and vision. And that is what we are here to hold you accountable to your mission and vision. And so if your mission and vision you are not working towards your mission and vision, and you're telling us the same, that is concerning to me, concerning to the committee. We can zoom in on some of them. One of them, you reported on EMS's response, rural response to P1 emergencies, and you gave us a figure in, I can't remember the figure now because I don't have it in front of me, but somewhere in the 40s, if I remember carefully. Maybe my figure is a little wrong, but that's not what I've seen on the ground. I'll give you an example. I was recently, the Education Portfolio Committee recently visited schools in the Umkhanyagude district. And on my way back from there, I passed Otombotini, the CHC. So I decided, let me stop there and let me have a conversation. Their response, they told me that, and they gave me an example. They had twins that were born premature at 26 weeks. One twin was just over a kilo. The other one was about 700 grams, which is unusual at 26 weeks. But they had to bag those twins from 3 o'clock in the morning to 5 o'clock in the afternoon. EMS only arrived at 3 o'clock in the afternoon to collect one or to collect both. When they tried to transfer them, one desaturated, they had to bring the baby back. And then at 5 o'clock, the EMS took and came back and then transferred. They survived the CHC. We don't know what happened in the higher levels of care. But overall, their response time in percentages was 13% of the target. So they could provide that level of care. I don't know about overall. So how is this, who provides you with these figures that you come up with this average that you present to us here?
Thank you, Honorable Chair. The concern is noted. Firstly, about the comment from Jack, I think it was a slip of the tongue, because if we look at the priorities that are set for 26-27, there are highlighted areas like pandemic and climate preparedness, health information system strengthening supply chain and distribution systems, which are priority areas that we are prioritizing, particularly because of the audit outcomes that we have, including strengthening financial management system. So the overall department of overall 26-27 annual performance plan will be really focusing on those areas in order to turn around the financial position and the audit outcomes, and actually making sure that we also improve on our audit outcomes. Then in terms of the EMS response, if Chair and honorable members can look at the estimated performance of 25-26, it's around a 26.7, which speaks to the current challenges that we are experiencing for EMS. However, with the interventions that we are planning to do, including our engagements with West Bank, National Treasury, the PPP model, that is why we have improved, we have set a planned 39.1% improvement from 26%. So it sort of does align with what the Honorable Chair observed, the performance of 26%. But we are hopeful that the investments that we are going to make, the interventions that we are going to do, will take us slightly more to about 10% more improvement in our 26-27 APP performance.
So is that reasonable? Do you think it's achievable?
We are hopeful, because if I can make an example, and I think the fleet manager will speak to that, with the interventions that we have implemented, particularly with the turnaround and our engagement with National Treasury and West Bank, I think as of late last week, we have seen an increase in the number of ambulances that have been returned to about 150. When we were last in this meeting, Chair, I reported that we had 132 ambulances. As of last week, we had 150 ambulances. So we are seeing an improvement in the turnaround time of repairs by West Bank since we've started this whole process of engaging them and bringing in National Treasury on board. Thanks, Chair.
Okay, thank you. So your commitment then is that you will set realistic targets, and that when we look at the report backs, you should start achieving those targets. Okay. While I have the chairperson of quality of life here, and we're talking about targets, I had written to you. I'm not holding you accountable, but I had written to you because one of the issues that the department deals with is severe acute malnutrition. And we're having many babies dying as a result of that. It's not their fault, they received the problem. So when we have that gathering, hopefully, of the different chairpersons, I think we need to take that. It just came to my mind now. I thought I should just mention it. So thank you for that, chairperson. But I think it's important for the department to then, preventive medicine is always good, so not that we need to ask you about the target. You had in your targets regarding bursaries for nursing students. I think you have there a target of 120. So
Yes, Honorable Chair.
you want to give in the next financial year, you want to set aside money for 120 bursaries to nursing students.
Yes, Chair, because this is the only way that we begin to build the pool of nurses that we require. Chair, if we can see that in the 2025-26 financial year, we had targeted 240. But because of our financial constraints, we decided to halve that at least by 50%. Because even as much as we are under financial strain, but the nursing colleges, we rely on the production of nurses by our nursing colleges.
Okay, so you've preempted my next question, and that was going to be, why did you reduce it? So that answers that question. However, if that is your intention, then don't you already have a surplus of nurses out there? For example, we heard, I don't know whether it was here or during Scopa or somewhere, where I think you mentioned that, you know, you had advertised 100 posts and, you know, 4,000 people had applied. What are you trying to achieve by giving these bursaries? Then don't you have enough out there?
Thank you, Honorable Chair. Honorable Chair and honorable members, will remember that we have recently started the new qualifications for the diploma in general nursing, science and art. And the current pool of nurses that we have do not have all the basic qualifications. Most of them that we have will either be enrolled nurses, enrolled nursing assistant, or singly qualified professional nurses. We still need to recruit and train nurses for the new curricula that we've started last year. For instance, after about 4 years, it's only this year that we produced about 400 midwives, which means for the past 4 years, we did not have any midwives, hence the shortages in our labor wards and so on. So we need to continue training in line with the new curricula.
So those 400 midwives that you produced, you taking them all on?
Yes, most of them were staff that were already in our employ. Yes.
So maybe it explains my next one. Because you speak about neonatal deaths. Now you would see the trend is on the increase.
Mm.
What have you attributed that to?
It's multifactorial, Honorable Chair, but mostly it's shortage of skilled personnel, be it midwives, be it pediatric nurses, be it doctors, and so on and so on. Or it could be some factors related to the pre-existing conditions of the mother in antenatal care, where you might find that the prognosis for the child, particularly most premature babies, we have a high rate of women who end up with hypertension, pre-eclampsia, and end up having premature deliveries with very low birth weight babies that do not survive. So it's quite a number of factors. Thanks.
If the lawyers are watching this broadcast, they're going to enjoy the first part of your response, because you have directly taken blame for not having enough nurses, pediatricians, and everybody to prevent those deaths. But anyway, be that as it may. Okay. Enough for now. Let's move on to any honorable members, any follow-ups, questions, any inputs? Do you think the targets that the department is setting are realistic? They say it is. Yes, honorable member.
Honorable Chair, because you have given us that leverage of sending something, so
I can't hear you.
Honorable Chair, greeting, Honorable Chair and the department and my colleagues. I'm saying because you gave us that leverage of sending, you know, before everything is finalized, that's what we're going to be doing. Thank you.
Sharp. Thank you. All right, let's move on to the next presentation on the second quarter reports, financial and non-financial. I think so many of these targets and discussions have already been had about the non-financials, but please present it for the sake of presentation.
Thank you, Chair. I will allow Mr. Jack Cavender to present the second quarter performance report.
Oh, yes. Sorry. The agenda item is not complete. We did the APP. It says and budget.
Or we must do the go
Yes.
to the budget and come. Okay.
Sorry.
All right. We will then present the the first draft budget, Honorable Chair and Honorable Members, for 26-27. CFO is going to present. Thanks.
Good day, Honorable Chair members, HOD and colleagues.
Yeah, that's
I have first draft budget and MTF 26-27. This is the next financial period. We reviewed extensively the current spending trends and impact on budget cuts from previous MTF cycles, reprioritizing during the budgeting period, mainly underfunded cost of employees and non-negotiable items under goods and services. And this led to a revised budget allocation methodology in 26-25 financial year and 26-27 MTF period. The estimates were reallocated to prioritize cost of employees and then non-negotiable items under goods and services, and then negotiable items in that order. We made an effort to cover cost of employees, but that negatively impacted on goods and services. We reprioritized 1.056 billion from goods and services to cost of employees. And this could not cover 4.3%, which is the inflationary adjustment, as well as 1.5% pay progression, as well as increases in other cost of employee related spend, such as housing, medical aids, or medical allowances. And we're estimating cost of employee shortfall of 1.3 billion. By the same amount, goods and services were reduced, and we're projecting a funding shortfall of 5.4 billion. And this excludes projected savings from the financial recovery plan that has been provided and presented in the past. And we assume the same value of accruals and payable in the period 26-27 financial year. The summary of estimates by program. The main appropriation, 56.2 billion in 25-26, with projected overspend of 5.6 billion. And the revised estimate, 61.8 billion. Going into MTF period, indicative baseline 26-27, 58.8 billion. 27-28, 61.6, 28-29, 63.784 billion. And the percentage growth is 4.6% in 26-27, 27-28, 4.8%, and 28-29, 3.5%. Budget per economic classification is as follows. Current payments, revised estimate 58.5 with projected overspend 5.474 billion. Reprioritized baseline and indicative baseline 26-27, 55.6 billion. And then adjusted by 5%, 26-27, and 3.6%, 28-29. Transfers and subsidies. Projected underspend, projected overspend, 47,928,000, and the indicative baseline, 837,179,000, 2728, 874,738,000. Planning baseline 2829, 914,101,000. Payments for capital assets. Over expenditure in the current year, 78,821,000. Indicative baseline total spend 26-27 financial period, 2,347,000,000. Reprioritized 14 million, and then reprioritized baseline 2,362,000,000. And this reduced by 0.8% in 27-28 and increased 1.7% in 28-29 to 2,342,000,000 and 2,383,000,000 respectively. Payments for financial assets, 0. We were subjected to budget cuts over the previous METEF periods, and there's historical cuts that resulted in the total net per financial year, discounting COVID-19, totaling to 9.5 billion to date, with current financial period being 2,366,000,000. The 26-27 financial year shows an inflationary growth of 4.6% budget on budget based on first 26-25 first quarter figures, and we're under pressure and we're projecting over expenditure of 5.6 billion or a negative growth of 4.9% based on 25-26 or current financial year projected spend. Per program, a total amount of 306 million was cut from Program 1, Administration, and we reprioritized Program 2, District Health Services. These were forced savings to fund mainly cost of employees and the non-negotiable. Were affected by budget cuts, and these mainly were redirected to advertising, forensic investigations, travel and subsistence, telephones, including cell phone airtime data, municipal services, fleet services, leasing and photocopying of machines, and the non-negotiable items included infection control and prevention, security services, medicine, patient catering, etc. And these were protected from the cuts and allocated sufficient budget to sustain current level of services. The funding shortfall under goods and services is estimated at 271 million. While the cost of living adjustment and pay projections could not be fully budgeted and is projected at 47,102,000. The additional budget was to restore the baseline following the department's decision to cover cost of employees and non-negotiables. The 6% growth is due to the budget allocation method adopted in 25-26. However, these movements of funds were not implemented in 25-26 at the time of compiling this document. The growth based on 25-26 revised estimate is 2.43% and can be noted in the table. Non-negotiable items show positive growth of 2.6 billion, of which cost of employees is 904 million and goods and services 1,708 million. Additional budget of 321 million was moved and forced savings to district hospital to cover mainly cost of employees and non-negotiable items under goods and services. 14 million was reprioritized from Program 3, which is Emergency Medical Services, after the revised budget allocation method to prioritize field post and non-negotiable items across all programs. A reduction under other community services sub-program was also due to this budget allocation method, following the correct linking of staff that was previously engaged towards COVID-19 activities. The rest of sub-programs were reduced in line with the revised budget allocation. And the method to cover gaps under district hospital sub-programs as follows. District management sub-program reduced by 26.8 million, 5.8 million in cost of employees, and the revised allocation was moved to district hospital sub-program within the same item category. 20.9 million from forced savings under negotiable items was moved to district hospital sub-program for field post, 7.8 million, and non-negotiable, 13 million. 195 million was reprioritized from goods and services under community health clinic sub-programs. Appropriation of 120 million moved within sub-program to cover field post, 3.5 million, and close gap under machinery and equipment procurement plan, and the balance of 72 million via to the district hospital sub-program to cover mainly cost of employees, field cost. Community health centers appropriation reduced by 56.9 million, with 8.8 budget cuts from cost of employees and 48 million reduction in goods and services. Community-based services appropriation also reduced by 64.3 million, with 12.3 million budget cut from cost of employees and 52 million in goods and services, mainly the over-budgeted CCMDD program. A reduction of 33.9 million in HIV and AIDS program was the result of correct classification of nutrition program within the district health program grant to the nutrition sub-program. Nutrition sub-program was reduced by 3 million, 33.9 million movement from HIV and AIDS as explained, 37 million was reprioritized to cover field posts under district hospital sub-program. Corona services appropriation was reduced by 25.9 million, with 13.1 budget cut from COE and 12.8 goods and services. The net increase of 39.5 million is due to increase in machinery and equipment, which was within the district health program grant under HIV and AIDS sub-program, 36 million, and community health clinics, 3.5 million. EMS reduced by 127 million, mainly from fleet services and transport provided activities under goods and services. This is to cover non-negotiable items in Program 2 and Program 4, 15 million and 112 million respectively. funding shortfall is estimated at 206.5 million, of which the unfunded current work deposit estimate is 65.2 million and goods and services 151.3 million. Provincial Hospital Services Program, mainly the Regional Hospital Sub-Program, was affected by budget cuts from the previous MTF cycles, and an increase of 499 million was mainly to cover cost of employees and non-negotiable items such as your medicine, medical supply, laboratory services, patient nutrition and security services, and infection control related items. The remainder of the items are classified as negotiable and were affected by the budget cuts. 616 million was allocated to General Regional Hospital Sub-Program following the revised allocation methodology. The other sub-programs were reduced after the filled-in post and the non-negotiable items were catered for. 112 million was for savings from Program 3, Fleet Services and Transport Provided Departmental Activities. 87.5 million was moved from Program 5, Provincial Hospital Services, negotiable items. 116 million was from Program 6, Health Sciences and Training, mainly from cost of employees, 99 million, as a result of decision to cater for warm bodies, and the balance of 11.7 million for savings from goods and services under negotiable items such as travel and subsistence, training and development of staff. 40 million reprioritized from Program 7, healthcare support services, also from cost of employees, 20 million. And the balance from goods and services negotiable items, 19.4 million. 143 million moved from Program 8, Health Facilities Management, to cover field post and non-negotiable items. Machinery and equipment reduced by net 17.2 million. 20 million moved from medical equipment to cover SLA for the contracted maintenance and repairs of existing medical equipment under general regional hospitals. This move was mitigated by 4.7 million increase in the same item category within the sub-acute step-down and chronic medical hospital sub-program for the procurement of critical medical equipment. Funding shortfall is estimated at 1.745 billion, of which the unfunded warm bodies is estimated at 499 million and 1.2 billion being goods and services. Program 5, Central Hospital Services, reduced by a net amount of 87.5 million to cover non-negotiable items under Program 4, Provincial Hospitals. It must be noted that goods and services negotiable items were reduced by 337.7 million, mainly under the agency and support outsourced services item affecting the PPP budget and is not categorized as part of non-negotiable items. 260 million moved within program to partly cover the field-in post as per revised allocation method. The balance moved to Program 4 as mentioned above. There was movement of funds within the program aligning with the reviewed budget allocation method as follows. Cost of employee allocation increased by 152 million. Transfers and subsidies to household were allocated an additional 1 million. Provincial tertiary hospital services increased by 128 million, mainly funded from forced savings in the negotiable items in Central Hospital Services sub-program, 107 million to offset the under-budgeted cost of employees and 21 million offset the non-negotiable items. 1 million was moved from transfers and subsidies to household under Provincial Tertiary Services sub-program and was allocated to Central Services sub-program to cover under-budgeted medical legal claims, and machinery was reduced by 10 million. The funds were moved from medical equipment to cover SLAs for contracted maintenance and repairs. The estimated shortfall is 1.125 billion, of which the shortfall for the unfunded current loan bodies is 93 million and 1 million and 31 million. 1 billion 31 million is goods and services. Health sciences and training reduced by 116 million, mainly 99 million cost of employees and 11.7 million goods and services negotiable items. There was also a decrease in nursing training colleges, EMS training colleges, primary healthcare training sub-programs as depicted in table 7.9. 94.6 million reprioritized from cost of employees and goods and services to program 4 regional hospitals within the same items. Transfers and subsidies to households reduced by 5 million due to reduced bursary intake in 25-26 and were reprioritized to training and development to address the prioritized and compulsory skills program. Healthcare support, 40 million was reprioritized from this program. Healthcare support to cover cost of employees, 20 million as a result of decision to cover current home bodies, and the balance of 19 million was forced to cover savings from goods and services. Goods and services breakdown as follows. Medicine trading account reduced by 8 million and 16.7 million reprioritized from goods and services moved to cost of employees. Health facilities management, 143 million moved from this program and reallocated to non-negotiable items in program 4. The negative growth relates to the incentive portion and the health facilities revitalization grant that is allocated annually on conditional grant performance. Thank you. And then we have the MTF annexures to cover the period up to 28-29 in the tables after the presentation. Detailed breakdown. Thanks, Chair, members, and colleagues.
Thank you very much, CFO. Honorable members, this is your opportunity to make suggestions, ask questions, make input, suggest changes, tell the department what you are not happy about, what should be this way or that way. So this is the first draft of the budget that has been given to us. Our budget analyst has also sent us some information which was circulated to you prior to this meeting. And in that submission, there were areas of concern that he had raised regarding where we are currently and what the impact of that might be going forward. So this is the first draft of that budget. We will probably see more before the budget is then placed before us. And this is your opportunity because you will be standing up in the House at some point debating this budget. So make your inputs now, rather than waiting to stand up in the House and saying, no, we told you this and you didn't do that, and all the politics that we do. The opportunity is now. So who are the honorable members that want to make contributions? If you don't make contributions now, then I'll tell you then that you didn't make any contributions. So this is your opportunity. Nobody. Sorry, Honorable Doctor.
We'll use the channel to send to you our suggestion.
Okay. So they will say, the honorable members are saying they will send their contributions. But anybody want clarity, questions, all of that now? Yes, Honorable De Boer.
Thank you, Chair. I know that compensation of employees is draining the other budgets and actually causing service delivery backlogs, specifically EMS backlogs. So I don't remember seeing if there was improvement in the EMS budget, but I certainly hope that that it doesn't affect compensation of employees is not affected. Sorry, EMS is not affected by compensation of employees again in this budget, because it seems to be getting worse year on year, and we want to start seeing improvement in EMS. Thank you, Chair.
Who is going to respond to that, Acting HOD?
Thank you, Honorable Chair. One wants to say that all program areas are affected, from program 1 to program 8. If we look at the report here, 14 million, I think, was reprioritized from program 3, which is EMS, to fund compensation of employees in program 2. And I think we were cautious, and that was the least a budget amount that was reprioritized in all the 8 programs, because we're cautious that we can't take a lot of money out of EMS. But because of the pressures in program 2 and program 4 and 5, we also had to take a little bit of something out of EMS. Thanks.
The building and fixed structures, the machinery and equipment. I think the honourable member asked earlier about the improvements to our assets, basically, and then also replacing machinery that is non-functioning or fixing it, for that matter. Because I remember when we did some oversight, there were some hospitals that couldn't do x-rays or even the scans because their machines were broken. So they had to transfer patients, which was an added cost now, to actually get those x-rays and scans done. So, the increase is actually quite low, and I think might, if any, only improve the current failures, and the forecast, future failures might not be addressed. So I think that the increases there need to be re-looked at, particularly the machinery and equipment in the hospitals, because we can't be incurring other costs because we're not repairing what we actually have. We're not looking after the assets, so it's affecting service delivery, and also incurring transport costs to send patients elsewhere to get their x-rays and scans done. Thank you, Chair.
Thank you very much. Any other honourable member? Yes, honourable member.
Thank you very much, Honorable Chairperson. I think my concern would be around the shortfall, the funding shortfall for Program 4. And it is shown that the some of the affected items include the municipal services. And you know, these days that it has been said that if the municipality does not get what is owed to them, they should cut the services. So I think we would like to get an indication, Chairperson, as a committee on how the department plans to avoid facing terminations in a case where, because there is a projected shortfall, that we are not able to meet the payments to the municipality and or what is owed to the municipality. If then the hospitals get affected, how are we going to, or how is the department going to deal with such, Chairperson, especially as it relates to the municipal services budget? Thank you.
HOD.
Thank you, Honorable Chair. CFO or Mr. Shezi is going to respond to that question. Thanks.
Thank you. Through you, Honorable Chairperson, greetings, and then to the honorable members and colleagues.
Mr. Shezi, just pull it a little bit closer to you.
Thank you, Chair. Hope this is better.
Yes.
So maybe perhaps if one can start with the concern around the perceived low growth on buildings and other fixed structures. Just to remind honorable members that we are actually narrating that that's partly due to the incentive allocation that we would ordinarily get as KZN Health, because we actually outperform the rest of our sister departments in the sector. And so if we also outperform them in the current financial year, we are then likely to also get that incentive additional allocation in the 26-27 financial year and the rest of its MTEF. So the perceived low growth that we are showing in 26-27 is because we received that additional incentive allocation in 25-26. And obviously we are hopeful that we'll still maintain the sterling performance that we have actually achieved in this regard. And then the next question in terms of the shortfall in Program 4. Actually, this cuts across all programs, I think, as the HOD has indicated, because the clinical programs, Programs 2, 4, and 5, are severely impacted by the funding gap in compensation of employees, obviously, because they are actually heavy in terms of number of staff involved. But in terms of the concern around specifically the municipal services as part of property payments, the in-year adjustments that we are, for instance, embarking on, even in the 25-26 financial year, are exactly to assist us, to shield us from those service terminations by the various municipalities. But again, the financial recovery plan, spearheaded by Provincial Treasury currently, is to identify those areas of savings leading to those efficiencies that will free up cash from elsewhere to then prioritize such areas like your non-negotiable items and the very municipal or property payments and municipal services. But again, the adjusted allocation that we have received in 25-26 and is also accrued for the rest of the MTEF per the budget speech 2.0 by the National Minister of Finance. A huge portion of that additional allocation is actually going to assist us minimize the impact of accruals that we have inherited from prior financial years, as the honourable members will recall. And the important thing is that that additional allocation or the top-up is actually for the rest of the MTF. If members remember the 20.7 billion, which is spread over 3 years. So we have already for the current year, as a sector, received that 6.7 billion, of which 1.39 billion came to KZN. So a huge chunk of it actually will go towards these goods and service items, and then actually minimize the impact as a result of accruals. It's not enough, because we're looking at 3.2 billion worth of accruals and payables, but this is just 1.39 billion. It will go somewhat in terms of minimizing that impact, as it were. Thanks, Chair.
Are you covered, Honourable Member? Any other questions? None. So,
Chair,
yes, Honourable
Just-
Nkonyana.
I've raised my hand already. I think
sorry,
please.
Sorry, I haven't been alerted and I'm for some reason disconnected on my computer, but yes, proceed, Honourable Member.
Okay, thank you, Chairperson. Greetings to you, greetings to our members and to the officials present in this meeting. Chairperson, I just want to welcome the budget analysis that has been done by the CCFO just now. But I haven't heard anything about the medical legal claims, that how much did they pay for the medical legal claims? Because that's the money that is taken from the department, showing a lot of bunch, yet I don't know that money has been budgeted or not. Secondly, we want to hear about those who have been suspended, that are they still on suspension? Are they still paying them? For how long are they going to be suspended? Thank you, Chairperson.
Any response?
Thank you, Chair. I'm going to answer on the suspension. Then the finance team can answer on the medical legal claims. We only have one staff member that is on suspension with pay, because we have stopped suspending people with pay. We opt for precautionary transfer to another facility or another office, in order to ensure that the person is productively employed while waiting for the case to proceed. In that case, the reason why it's still, we have made efforts to recall the manager back to work, which I did, I think 2 months into assuming the acting position, but the particular manager put up a legal battle that we are still dealing with. So it's only one case. Thank you.
Thank you. What is who is responding to the other part?
Mr. Chair, respond to the issue of medical legal claims.
In terms of how much has been circled to date, that's part of the next agenda item, Chairperson. Perhaps if we can pen that for that presentation.
Yes, thank you. But that brings me to a question. Arun Kwanyana, do you have any follow-up?
No, sir, no, Chair. I think I'll still wait for the answer on the next meeting, as the CFO said.
Okay. On the medical legal claims, yes, it will be in the next report. However, in this one here, seeing that in this financial year already, you had under budgeted for medical legal claims. How are you in this upcoming budget going to budget? I know it's unpredictable, but you would have an idea of how many claims against the department. And if your legal unit is working properly, you'll know how many you might be successful with, because you'll know how many you can successfully defend or not. Some file is lost or something, so you will know. And although it depends on who's defending and who's prosecuting, you know, the case can go either way. But how are you going to mitigate against a future under budgeting?
Sessions?
Oh, thanks, HOD, and thanks, Honorable Chairperson. It's quite a difficult one indeed, in the sense that because we are forced to actually budget for, or to set a budget aside for these medical claims. From this very inadequate baseline, at the beginning of the financial year, meaning in the main appropriation, we do set aside a few pennies, and then we monitor that in year, such that during the adjustment estimates, which is the period we are actually in as we speak, we then will actually top up, provide a bit of top up towards the claims that would have already been settled, but also projecting what still lies ahead in terms of the rest of the financial year towards 31st March of the following year. So the same thing has actually happened this year, and we will speak to it in terms of the next agenda item. But the increase under transfers to households, as can be seen in slide number 8, are just to sustain the very allocations. If you look at percentage growth over the 26-27 MTEF, we're just sustaining or trying to sustain what we currently are spending on these claims. Hopefully the multi-pronged strategy that we are working on as a department is going to assist, number one, help further incurrence of these cases that lead us to incurring these claims after all. But then where the horse has already bolted, then the negotiations and the strategies from the National Department of Health are also hopefully going to yield some efficiencies going forward. But for now, we are just sustaining in terms of the numbers that we are setting aside towards these transfers. Thanks, Chair.
Right, thank you. Then following on from, I think it was Honorable Masiko who asked a question about municipalities. At our next meeting for that current period where we are at, so if the meeting is in February, don't give us December figures. Give us at that period when our next meeting is held, how much you owe each municipality a report. Any objections to that, honorable members? None. Thank you. So resolved. So we'll get that report, and then the committee can monitor what is owed, because we had an incident, for example, in Umhlatuze, where the municipality cut power to all the clinics some months ago. So somehow it landed on my desk, and I said, why are you doing that? How can you cut the clinics? You know, I spoke to somebody in the mayor's office and deputy mayor's office, and then they said, okay, we'll reconnect it, but the department must pay. I had raised it with the HOD, acting HOD, and I think you had resolved that problem at that time. But the thing is that happens, and then it causes chaos. So we need to have those figures. The department is known for paying its rates and paying the Department of Public Works, and you pay up, although you delay slightly, but you do pay up. So we understand those pressures, but we'll get that report from you. Mr. Shezi already spoke about my next point, which was the adjustment budget, and it has been committed to accruals, probably settling those kinds of things. And it will probably cover that. So what worries me is that same slide that you referred to, slide number 8. So your budget is going to improve by, or have an additional allocation of 2.56 billion rand or so, 4.6%, but it cancels out, because if you look at it says here, based on your 25-26 projected expenditure, you go to 4.9%. So the question is, and it's related to your COE, because it is the constant pressure across all departments that's causing all your problems. So I had raised this informally at the beginning of while we were still chatting. Can't you take all that money and just put it into COE and just fix your COE and say, look, or take it and put it into EMS and say, look, let's fix EMS once and for all, done and dusted. Can't some, we are stupid. We are not the finance people here. So maybe you can tell us, I mean, what are your views on that? Fix that thing, done and dusted, because what follows from there is your sustainability of your COE. You're taking on all these doctors and nurses and specialists, and you advertise, it looks very nice, and we'll have them in our facilities. But then come 26, 27, we're looking at mitigation now. So getting happy that, look, I'm getting 2.56 billion rand. Then where? What next? You can't keep kicking the can down the road, wake up in the morning and say, okay, now we're getting this, so we'll do this. So leave your adjustment budget. You've answered that you're going, you've committed it in another way. But how are you going to solve this problem?
Thank you, Chair. The COE problem can only be solved by an additional budget to the department of 7 billion. That's the only way.
But you're getting 2.56 now. Why don't you just use that for now?
Yeah, as Chair has indicated, some of that part of that budget is spoken for. Accruals, statutory obligation for ComServes and medical interns, buying beds and linen, although we are negotiating with National around that, but it's already spoken for from National, part of it. The 1.3 billion is spoken for all those items, and it's mandatory. Or permanent employment of community health workers, 5,000 plus community health workers to be permanently employed from that 1.3 billion.
No, but is that your adjustment?
The total.
Or leave the adjustment.
Mm.
Leave it one side.
Mm.
I understand that there are commitments for all those things. It's already in your baseline that you had. You're just adjusting you're getting that addition and you allocating it. I know it has to be done.
Mm.
I'm talking about this draft budget, 26, 27, that additional 4.6% that you're getting. Why, yeah.
Can you respond? It's Kerry.
We'll come to CFO. I see Mike is on, but let's start with Mr. Shezi there.
Okay, maybe my contribution on this one, Honorable Chairperson and members, is that if we were to just take the entire added allocation year on year and put it under COE, it will solve a budget deficit problem within COE, but it will create a fiscal cliff on the rest of the economic classes, which is why the financial recovery plan is multi-financial year linked, and which is why also we are progressively funding COE as we did in the current year, taking R1 billion from GNS. We are doing the same again in the next financial year, whilst our financial recovery plan actually addresses to lower the growth, the expenditure growth within goods and services, such that then at the end of the 5-year period, because it's a 5-year plan, then we hopefully will achieve that balanced outcome between expenditure and budget. If it does happen sooner, it will actually be a very welcome kind of an occurrence. But as things currently stand, excluding what still lies ahead in terms of the top-ups, the adjustment allocation, because as we are saying, the projections for now exclude the costed impact of the financial recovery plan. It also excludes the additional allocations that are still due to the department. So then the balanced outcome is actually going to be achieved sooner than the projected 5-year period that we currently are working on. But maybe as a parting shot, the additional 4.3% that is seen as an increase, it's just inflationary. The very municipal services grow far above the CPI. The very property payments in terms of security, cleaning, gardens and grounds, catering for patients. Actually, our medicines, medical supplies, the growth there far exceeds even CPI, because medical inflation is usually about 3 or 4% above CPI. So the growth rates that you are seeing there, the point we are making is that that's just inflationary. There is no room for growth. It doesn't allow us to actually invest a portion of that back to the very accruals and payables that are very difficult to realize come financial year end. So that would be my response. We are progressively working towards lowering the gap or even depleting the gap within COE, because obviously it becomes first charge. It doesn't even respect the boundaries of cash blocking, because salaries still go through. So ultimately, we must just fully fund COE. So the chairperson is actually correct. But over time, we can't do it once off, because then it creates that unintended fiscal cliff, so to speak. Thanks.
Okay, we shall quote your fiscal cliff repeatedly, because that's exactly what it is. And you have compounded the problem rather than providing a solution. So in essence, it can't be done. And you have provided many reasons. Some may even aver that it is excuses why you can't do it. But anyway, be that as it may. I'm being reminded of the time because we need to move to education, which is after this. So I'm mindful of the time, but I think it bears proper interrogation, because if we don't ask the questions, then what will happen is that when we make remarks later, then, but we've noted it, and I think we'll see other drafts of this that will then be able to interrogate further. Let us move to the next presentation. Honorable members, just so that I'm not accused of not giving you an opportunity, is there anything else based on the comments and responses that you wish to question or add? Nothing? Nobody? Okay. Very good. Let's move to the next one. Presentation on second quarter reports, financial and non-financials. Who's doing this, acting HOD? Please flight it. Is it this one? Oh yeah. Yeah.
Chair, I'll go straight to page 5.
Just let it appear on the screen, please. Where are we? Ms. Matite? Very good. Page 5.
Slide 5, please.
What's the difficulty? Okay.
Thanks, Chair. And good day again to honourable members, HOD and colleagues. So on slide 5, we just reflect that there are 34 quarterly indicators in the APP, and out of the 34, we've achieved 44%, 15 of them in this quarter, which is an improvement on the previous quarter of 38.2%. We go to slide 6, which gives you a breakdown per program, with the program 1 showing 100% of targets achieved. Program 2, 52%, that's district health services, 1,427, whilst program 3, 7, and 8, with 2 targets each, we were unable to achieve the targets for the quarter. On slide 7, for program 1, we report around NHI capacitation for the districts, especially the contracting unit sites, where 6 of the districts have been trained in terms of NHI preparedness as far as the contracting units are concerned. On slide 8, we just reflect the breakdown for program 2 for target achievements. Go to slide 9, where we note that we have screened 80,960 grade R learners against a target of 41,000. On the next slide, slide 10, we are showing positive results for HIV positive 15 to 14 years, 15 to 24 years, child remaining in adult in ART as well as adults, and the adult suppression rate below 50 for 12 months. It continues on slide 11 in terms of the suppression rates. We're seeing positives in terms of TB success rate, as well as the MDR treatment success rate. In terms of patients, TB patients starting treatment under 5 years and older, we had 18,160, and those under 5, we had 708 against a target of 1,296. Slide 12, we continue with the MDR in terms of patients that have started treatment with 679 against a target of 809, and we have close to 1.5, 1.6 million patients on ART adults and 24,000 children on ART. There are various achievements which we reflect on page 13 in terms of the improved management of children and implementation of the metrics of intervention to improve HIV prevention, implementation of interventions to curb the spread of HIV, which includes condom distribution as well as PrEP, improvements noted in the implementation of treatment literacy and patient adherence plan, treatment success in both drug DS-TB and multi-drug resistant TB, through improved linkage to care and implementation of BPAM and 6-month shorter regimen for drug-resistant TB. On page 14, we reflect on some of the challenges in terms of the testing coverage at 73%. We do have patients that default on ART. And we've also noted that there has been some data cleanup, which have shown some differences between targets achieved for Q2. On slide 15, our couple year protection rate is at 52%. And we note that we have 284 deliveries for clients between 10 to 14 years. There are positive results for antenatal visits before 20 weeks at 78.6% against a target of 76.5%, whilst the postnatal visits, mother postnatal visits are sitting at 85.3%. On slide 16, in terms of child health, the infant PCR test positive at birth rate is at 0.37%. Immunization coverage is at 77.6%. Measles dose second dose is at 81%. Our case fertility rate for diarrhea is at 1.3%, whilst our pneumonia case fertility rate is at 1.6%. In terms of deaths from SAM, we are at 7.9%, and our cervical cancer screening coverage is at 67.2%. On slide 18, we do note positive engagements yield positive results for ANC attendance, and there's been increased access to respiratory support equipment. In terms of challenges, so the low couple year protection rate, limited use of contraceptives, and the low immunization coverage due to limited catch-up vaccination drives. On slide 19, interventions are marketing larks to women of childbearing age, continue to raise awareness and implementation of 2 strategies that's around health promotions, as well as the child and teenage pregnancy strategy. And we will ensure implementation of the vaccination catch-up drives. Slide 20, in terms of mental health care, treatment rate is sitting at 0.09% of primary health care headcount, whilst we do note that we have all of our community healthcare centers have at least one mental health provider appointed. On slide 23, in terms of, 22, in terms of EMS, our response times for urban response rate is around 28.2% under 30 minutes, whilst the rural areas we're sitting at 44.7% under 60 minutes response rates. We do note on slide 23 the challenges in terms of fleet management, which are ongoing, as well as that our fleet of vehicles are aging. There is continuous engagement with the fleet management, and we've managed to we will be procuring 30 new ambulances for this financial year. On slide 24, in terms of program 7, stock out rates for medication at the depot, we're sitting at 5.8%. At primary healthcare and hospitals, we're sitting at 2.9%. The challenges are that there have been supply constraints. I'm on slide 25 in terms of raw materials, batch failures, as well as packaging for drugs, as well as the demand does exceed what we forecasted. The interventions are looking at maintaining the redistribution and rationing of stock, as well as provision of therapeutic alternatives to patients. On slide 26, we look at preventive maintenance expenditure sitting at 42.6% against a target of 47.6%. And we do note that 18 of our capital infrastructure programs have been completed against 20. There is an increase in breakdowns, and there has been delays in terms of paying some service providers, which has impacted negatively on the progress of projects. Districts have been encouraged through meetings to regularly service the plant and equipment, as well as there's an engagement to implement an invoice tracking system to fast track payments and continue to engage internally with SCM. So that's a presentation for Q2. Thank you.
All right, honourable members, here's the department's performance for this period. Here are all the questions that you want to ask regarding the different performances and progresses and reporting. Honorable Kwanyana had a question in the previous round So Mr. Shezi skillfully deflected it to this presentation. You can start by answering that question. And then we will come to the honorable members after that. No, we're talking about the non-financials, yeah.
Honorable Chair, I think
Yeah.
that will come from the second quarter financial.
Financials, okay, we'll just remember the question, right? Okay, honorable members, yes, Honorable Mkhize.
Thank you, Chair, and greetings to honorable members, your good selves, and HOD and the entire team of Department of Health. Chair, I was just browsing through the report, and I wanted to check that the department seemingly has had a problem with EMS and the West Bank contract. And for me, it's a prolonged problem that we all agree that it does not help the department. I just want to find out if there is any way of disengaging with West Bank and finding other alternatives as far as the EMS is concerned. I also wanted to check, Chair, with the shortage of mobile clinics, particularly in deep rural areas. In other rural areas, we'll find that a mobile clinic will come once a week, or in a bit better times, you'll find that they will come like 2 times maybe a week. But there's seemingly a shortage of mobile clinics, especially in areas where there are no clinics at all, or in areas that, according to the designation of the department's policies, it does not require that a department can actually build, according to the population, that a department can actually build a clinic there. If we have any means of trying to address the shortage of mobile clinics, we understand with the budget cuts and all, but I think it's important that we find ways of increasing the number of mobile clinics that we have in the province. I was concerned about the limitation of case finding as it relates to TB. But I get comfort in finding out that the department actually procured a mobile chest X-ray. 2 of them, if I'm not mistaken. Are they 2 or 4? 2 or 4? 4. Okay. I think that helps. But I just want to say, Honorable Chair, I think at some point, the department has let go of the awareness part of the TB awareness. Now I feel like we're no longer doing enough. It's like, oh, people know that there's TB, and I mean, you must just go to the hospital and find out if you have TB or not. I'm saying this, Chair, because I remember the Deputy President sometime this year, I think it was this year or last year, I'm not sure, but sometime this year came for a TB world, what. But those kind of awarenesses, they don't necessarily need to be big events like that. I think the department should, if they're doing it, I'm sure they are doing it, but I'm just saying it's not enough. If they are having awareness campaigns as it relates to TB. I understand many people don't even like to be tested for TB. One man ran away when the department came for when they were with the Deputy President. They also run away from taking medication, and you'll have cases of default, people that are defaulting and all that. It's quite
we're a very challenged society in KZN or in South Africa. People don't care about their own health. And unfortunately, it is us that have to care about their own health. They just do not care about when it comes to taking medication. The other time I did ask the HOD about the 1 million missing people that have defaulted or stopped taking medication or never took medication. That tells you that we have serious issues in KZN, and it also tells you that you are not going to have or see a decrease in infections, in new infections, if you have people that are unaccounted for, that are over 1 million. Where are they? What are they doing with who? And it means you're still going to have new infections piling up, also straining the department even more from how things are already. Chair, I just wanted to make those few comments. Thank you.
Thank you very much. Yeah, most of them were remarks. However, in your remarks, you did raise the issue of mobile clinics. Maybe the department can respond to that. You raised the issue of TB quite clearly, and thank you very much for that. I must admit that there is some responsibility that we bear as the committee as well. And I must tell you that we are still engaging in the process of establishing the TB caucus in the province. So there is some movement in that regard, in that there is some paperwork before us. We need to finalize it. It will come back to this committee. This committee will be very involved in the advocacy and coordination of addressing TB in KwaZulu-Natal. As it was in the past, the chair of the Health Portfolio Committee chairs the TB caucus. So that is something that will still come back to this committee for establishment, and it will be a resolution of the House eventually. So we are moving in that direction, but I think most of your submission were comments and advice. Thank you very much. But however, should the acting HOD wish to direct, or whether she wishes to respond, I'll hand over to her so that we are not accused of not giving them the audi alterum partem.
Thank you very much, Chair. Comments from the honorable members are noted. I will start by responding to the issue of mobiles in the province. Given that the KZN province is a vast, largely deeply rural province, we do try as much as possible to extend our mobile services to those underserved areas. However, because of the limited financial constraints, we are limited in terms of rapidly expanding by procuring those mobiles and also recruiting staff to staff those mobiles. But I think in the current financial year, there are mobile vehicles. Mr. Mdebele will actually respond to how many new mobile vehicles that we have bought for the current financial year, either Mr. Mdebele or Mr. Shabangu from Fleet Management. However, those mobile vehicles also need staff. So whilst we have bought a mobile vehicle, we must also, as COE, must find money to employ personnel. But also where we find that there is a dire need and the access is really limited, we reprioritize from the existing mobile points, which then disadvantages the existing one. Say, for instance, where the mobile point was going twice a month, we will now have to move this one to go to another point. And then this one where you are servicing twice a month will now have to be serviced once a month. So we play that balancing act, but we do try now and again when we've got a little bit of budget to procure some additional mobiles. Our fleet manager will just give us the figures of that and how many we have currently in the province. In terms of case findings, yes, honorable member, it is true that we have a challenge of TB in the province, particularly case finding particularly amongst children 5 years and under 5-year-olds, both for TB, for drug resistant and drug sensitive TB. As Honorable Member has indicated, earlier this year, a program of TB in schools was launched, which is a program that we have been vigorously implementing in the schools, particularly during Q1. We sort of reduced our activities in terms of school health services to focus on the TB program in schools, case finding and referral. And that TB program in schools actually also links the children with the families, so that if there is a suspect in the school, then we are also to trace families. And I do think also the work of the TB caucus will also assist us in terms of improving our health outcomes in terms of TB, particularly around TB case finding. Thanks, Chair. Mr. Shabangu.
Good afternoon. Good afternoon, Chair and honorable members. I think, Chair, the honorable member is absolutely correct that the budget cut over the past years has made it impossible for the department to meet the demand in terms of availability of ambulances and EMS vehicles. And again, the situation was exacerbated by the challenges we had with WESTBank, the RT46 contract. I must say that, Chair, the contract with WESTBank is ending on the 31st of March 2026. We have, in fact, engaged them in terms of our challenges that we had. We've engaged also National Treasury, who has also come on board to try and assist us. The reality is that if we were to opt out of that contract, we would have to get a permission or authority from National Treasury because it's a transversal contract. Again, Chair, the reality is that we need funding to buy more, to procure more vehicles. In the current financial year, we have procured 13 mobile clinics that are currently, yes, available. They have been delivered from the Department of Transport. There are other options that we are looking at, Chair, in trying to mitigate the challenges that we have. For instance, the issue of P, it is going to be one of the initiatives that would really assist the department in terms of mitigating the ongoing challenges of operational ambulances. And again, we are strengthening the roadside assistance program that is within the department that would obviously be tasked by conducting on-site repairs and monitor the service and also monitor servicing of the state vehicle. But the reality is that, for instance, a diesel vehicle would be required to go for a service at around 20,000 kilometers, and normal petrol would go around 15,000. And these vehicles would work 24 hours. Some would accumulate around 1,000 kilometers a day. Essentially, then it means the vehicle would only operate for a month, and then would have to go for a service or other major repairs, which then becomes a bit of a challenge with us. But the reality is there are other interventions that we are trying to perhaps to resolve the current situation. But WESTBank has from time to time let us down in attending these vehicles, and it's a matter that was elevated to National Treasury. We are having ongoing engagements on a weekly basis, basically to monitor the progress in terms of getting more vehicles back on the road. But again, the age of the vehicles that we have, really, it's a bit of a challenge, because once a vehicle reaches above 300,000 kilometers, it would definitely require more service and major repairs.
Okay.
Yeah, thank you, Chair.
Thank you. Any follow-up, honorable member? Covered. Thank you. Any other honorable member? No. I'm going to go back to slide 5. You tell us that you've achieved 44% of your indicators, of your targets. So this report is for this period of time. I don't know if Mr. Govender is going to answer this or yourself. How are you on track towards the end of the year with regards to achieving your targets completely? What do you foresee?
Honorable Chair, we are working on improving our performance at least we are aiming to reach at least 60% by the end of the financial year, because that is our baseline. That is where we come from the previous financial year. So we are actually have started doing more rigorous and granular analysis of our performance and actually monitoring performance on a monthly basis, so that we are not surprised by end of the quarter that we have not met our targets. We've had an engagement, we've called an extended management meeting with the district directors, because they are the ones responsible for operations at a facility level, at a district, and monitoring facility performance. So we are anticipating that at least we achieve 60% by the end of the financial year. Thank you, Chair.
Are there any reasons why TB treatment and other treatments are not started? Because you say, you're not achieving targets of starting treatment. So the patient, I'm trying to understand this. So the patient presents, and then you don't start treatment. Is there a reason?
One of the reasons is the issue that because these are children, they require parents, and sometimes they are brought by caregivers and so on to the facility. But we had an interrogation of particularly these indicators a week ago, Honorable Chair. And one of the common findings that was reported from the various districts was the issue of data. That much as we see that there is underperformance, particularly in the TB indicators, we actually spent some time discussing this performance around TB data. And we found that I think about more than 3 districts reported that there are data issues, and they've actually started data cleanups. And when they do data cleanups in terms of accuracy between different sources of data, your registers, your tier.net and web DHS, they found that some of the data from the hard copy registers doesn't get to be captured in web DHIS or in tier.net. So we resolved that all of the districts must go and do data verification exercises and cleanup, so that we can see what we achieve at least in the next month, and see whether there are any changes. Thanks, Chair.
Okay. With regards to your limited catch-up in terms of vaccination drives, slide 18, why are they limited catch-ups?
Part of our campaigns that we do are driven by school health teams and ward-based outreach teams. Now, because of limited resources, Chair, when a new campaign comes on board, it then impacts on the existing work and campaigns. Like we're saying, in the first quarter, we're driving the TB campaign in schools using school health teams and ward-based outreach teams. And as a result, all these catch-up drives where we go to hard-to-reach areas or villages or whatever, will then compromise in favor of the TB in schools campaign. So we are going to be looking at that in terms of now ensuring that we continue with the campaigns, immunization campaigns in the hard-to-reach areas.
Oh, this is very worrying. That response is very worrying, because there's a saying that all that glitters is not gold.
Mm-hmm.
Now you're taking what's new and giving it priority over what's old and works. And then, when we don't immunize, I don't have to tell you. But anyway, The explanation is noted. With regards to long-acting reversal contraceptives or your LARCs, there's a current shortage, or there was a shortage, of your Implanon in particular. What's happening there?
Can I be given an opportunity to check that, Honorable Chair? If Mr. Langa can check with pharmaceutical services, the shortage of Implanon. Thanks.
Yeah, there was a period of time when Implanon and even injectables were not readily available. So this becomes a problem because under your long-acting, your injectables also fall into that category. All right. He can check so long as he might ask the man who told us about the syringes the last time, the insulin syringes. But anyway, okay. We move on to the financials then.
Thank you, Honorable Chair and members. It's the financial performance at 30 September. This is the end of Q2 or half-year period. The overview. We are projecting overspend by 5.386 billion, which is at 50.9% by end of September, attributable to the accruals and payable opening balances that we brought into this financial period mainly. As indicated in the budget presentation, compensation of employees is what we prioritize and fully fund. We are projecting overspend of 1.3 billion under goods and services. Projecting for shortfall of 4.1 billion following the reduction to fund cost of employees. I will then take you through to in-year adjustment, section B of the presentation. We are affected by the budget cut from previous MTF period. Most of the discussion in the adjustment has already been mentioned in the previous presentation, but then I'll take you through each program. Program 1. This includes 185 million for outstanding licenses, computer services, 9 million audit fees, 3.5 million to find food patient nutrition, and the monthly management fee for October and November, as well as 6 million for fleet management tracking services. Program 2 reduced by 50 million. Breakdown. Savings under district management hospital, 89.5 million, mainly from medicine, 24 million, medical supplies, 71 million, and lab services, 40 million. And this was redirected mainly to your fleet services and property payment, 38 million and 8 million respectively. An amount of 9 million redirected to district management services to cover fleets. And under community health clinic sub-program, increase of 13 million to reduce pressure on property and fleet services. Program 2. District Health Services, 4.8 million reprioritized to cover community health centers for property payment and fleets, 8.2 million to address shortfall under fleet and school health program, outreach services. Other community services sub-program will receive 307,000 from program 2 to cover fleets and an amount of 4.7 million reprioritized to cover coroner services fleet. 2.7 million reduced under nutrition sub-program as a result of over budgeting. 79 million moved to program 3 EMS to cover mainly fleets under goods and services for both sub-program EMS and planned patient transports. There is 48 million as well as 30 million respectively. Program 4, Provincial Health Hospital Services, reduced by 192 million. 163 million was from medical supplies, consultant business advisory services, medicine, and 15.7 million were also identified under TB sub-program. These savings were derived mainly from property payment, medicine, medical supplies, 8 million from fuel, oil, and gas, and then 4.5 million property-related services, medical supply, and psychiatric hospital services. The total savings from Program 4 was therefore moved to address negotiable items under pressure on Program 1 administration. Central hospital services reduced by 40.9 million. Within goods and services to cover negotiable items funding gap, Program 3 EMS, mainly related to fleet services. Program 6, Health Sciences and Training, increased by 712,000. And then 712 was moved to Program 6, Health Sciences and Training, to cover the shortfall under goods and services to fleets under EMS. And Program 7, Healthcare Support for Travel and Subsistence Negotiable Item under Orthotic and Prosthetic Services. There were also savings under Primary Healthcare Training Sub-Program, and these relate to development items, and they were covered under fleet services for nursing and training colleges. Healthcare support, as mentioned, decreased by 733,000. And Program 8, there was no adjustment. If you go to the detail, Table 1, expenditure per program is going to indicate that we had main appropriation of 56.211 billion, actual expenditure to 30 September, 28.588, and it's at 50.9%, and we're projecting overspend of 5.386 billion. Big pressures, actual expenditure as a percentage of appropriation, administration Program 1, 96.9%, and we're projecting overspend of 200 million there. Another one, healthcare support services, which was mainly appropriated at 353 million, actual expenditure 423. We are projecting overspend of 32 million. It's sitting at 119%. What is trailing behind is health facilities management, which was 1.9 billion, and the actual spend is 690 million, and it's at 36%, projecting overspend though of 11.6 million. That is what's catch-up stats. I'm going to then take you through to this was Table 1, expenditure per program. I'm going to take you again to Table 2, Table 2, it's not conditional grant, sorry. Expenditure per economic classification. This one is indicating cost of employees overspend projected was sitting at 50.8%. It's in line with the total spend. As we can see, it's the main cost driver, 1.379 projected overspend. And then goods and services, 4.1 billion projected overspend, coming to the total of 5.386 billion. This has come down from the initially projected overspend of 5.6 billion, and we're continuing to embark on cost savings measures. Taking you to table 3, conditional grants. Conditional grants is at 41.97 spend, and we're projecting to spend the whole 12.179 billion allocated. Up to this point, we have district health program at 42.71%, and this will catch up to full spend by the year end. Human resources training and development grant is at 52.87. Health facility revitalization grant is at 26.96%. It's also going to catch up to 100% by the year end, financial year end. National Tertiary Services grant, budget allocation 2.289 billion. Actual spend 1.36 billion at 45.25. I'm just going to mention expanded public works program, integrated grant for provinces is overspent. It's currently sitting at 55.27 against what would be the norm of 50% at 30 September. Thanks, Chair. I will end there.
Thank you very much. Honourable members, questions from yourselves, comments, input? None? Okay. Our budget analyst has given us a document that is slightly different, but it's probably related to the period of time when he prepared his document and a little bit of time that has passed for the presentation today. So, for example, and I'm looking at my screen, the second quarter performance gives us the administration overspent at 116.06%, which is different from, I think, what you put in table 1. Slight under expenditure at 48.2 at the next district health services. EMS at 49.79, so that's on target. Slightly over at provincial hospital services. And then over expenditure healthcare support services at 123.61%. And under expenditure of health facilities management at 36.60%. So I think that probably has to do with time lapse. We'll take your figures as they are, and we'll check it against Volindlela as well. So hopefully that's not too much. The committee will commit to continuing to monitor each of the programs as presented to us. We note that at 50.9% of expenditure currently, as a percentage indicates good fiscal discipline, which is commendable at the moment. However, we have noted your pressures. For the COE and goods and services, we've noted that that pressure continues and remains. And the committee notes and raises our concern regarding your accruals, which will probably result in another first charge and continue to create problems for you until you mitigate that. And of course, this strips the department of much needed funding that will be required, and you will need to tell us when you come to the third quarter presentations how you will continue to mitigate against that. You still have cash flow issues. And in your cash flow issues, we've noted probable non-compliance with Treasury Regulation 8.2.3, where all your invoices are still not paid within 30 days. And we would urge you to do your utmost to comply with that, and also report to us regularly about where there are areas of non-compliance with that, so that we may monitor that as part of our oversight work. So those are the concerns that arise out of this. Are there any honorable members who wish to raise any other matter? None. With regards to the next presentation on the fraud and risk management that has been circulated to honorable members, HOD, may I ask you to table it?
Thank you very much, Honorable Chair, and honorable members. The Departmental Fraud and Risk Prevention Plan is hereby tabled for the noting of the honorable members, but for noting by the honorable members.
Accepted, honorable members, that it is tabled. Thank you very much. We'll move on to the next one. Presentation on legal. We don't need a presentation. I think this is not correct. What we are having here is we have asked you for a legal opinion. You have sent it to us. I'm a little concerned that it is not the latest. There was a legal opinion that was produced by mere attorneys and others. That is the one that we were looking for. That was not just the 2000 and other one that we had discussed. It is not the latest legal opinion. However, we will consider if two things here. One, that you table the one that you had sent to us, and then I'm going to hand over to our legal advisor just to take us through the process therefrom. So are you going to table that?
Yes, Honorable Chair.
Okay.
Honorable Chair and honorable members, the legal opinion on the Ulundi relocation matter is hereby tabled for the noting of the honorable members.
Honorable members, the matter was circulated. Do we accept the one currently before us? Agreed. No objections. Thank you very much. Ms. Kozwayo, Advocate Kozwayo, over to you.
Thank you. Thank you, Honorable Chair. Honorable Chair, the opinion that is before us is the one that was drafted by the Office of the Premier, the Chief State Law Advisor, and this was actually submitted to the Portfolio Committee in the previous term. I think that was on the 10th of March, 2022. And then subsequently, the HOD at a meeting of the 24th of May, 2022, gave an undertaking that they had, the department has instructed mere attorneys who were going to appoint senior counsel as per the advice of the state law advisors, that the department's HOD was functus officio since the decision was taken by the former HOD Gumede. And as such, HOD Shabalala, the then HOD, could not make any decision on the matter. And then subsequent to that, Advocate Ngosi and Senior Counsel Potgieter were appointed by the department. And there was a legal opinion that was, I think it was tabled before the committee on the 2nd of September, 2022. And that opinion was actually a PowerPoint presentation without the source document, which is the actual opinion, and the committee wanted the actual opinion. And that PowerPoint presentation that was that was meant to be presented by the Chief Director Legal Services was then withdrawn by the MEC under the explanation that she was not briefed on the opinion and that report. So what we need, Chair, is that opinion of Advocate Bodhiter SC together with Advocate Ngosi, in which they were briefed by the mayor attorneys on the 24th of March, 2022. That's what is outstanding, Chair. And without that, we are unable to get back to the complainants and advise what then to do.
Okay.
Thanks, Chair.
So the way forward, I mean, the one that has been tabled now is fine. It does deal with the issue and opinion on functus officio as a whole, and it is an opinion from the Office of the Premier. However, our members, we shall request for completeness of the process, and hopefully that will be the last time, because we have already taken the other steps before we come back to a decision. I will ask the department to table that one for us at our next meeting.
Honorable Chair, I would like to indicate that the Senior Counsel Advocate Kosi had not completed the sort of the investigation. When I came in, they were still undertaking the investigation. I met with them about 2 months ago, and they required additional information. So we'll pursue them to finalize the report and submit to us.
That is fine. Let them do what they have to do. All we are asking is that you table that report and that presentation, that opinion that was already brought here and withdrawn. We just want it brought back. That's all. So that completes that matter. Honorable members, on the presentation on committee resolutions, all have been sent to you, and it is for your noting. On that note, we have already had our discussions and resolutions. What I didn't say at the very beginning is welcome to Honorable Dlamini to the committee. May your stay be good with us, and yeah, may we benefit from your guidance and input. Thank you very much for that, Honorable Dlamini. Having said that, honorable members, if there is no other business, going once, twice, 3 times, gone, the meeting is then closed.